Good afternoon. Before I talk, I might as well tell you that my accent is South African. I've lived in Israel 48 years. I lived 7 years in Boston, 6 months in Australia, and this is what you get. They tell a story. This situation is most unusual for me, but I must start with the story because it's appropriate. They tell a story of a homeless drunk in New York City who got onto the subway, and he looked a mess. He hadn't had a bath for 6 months. He hadn't shaved. He smelt of alcohol, of urine, anything else you can imagine. And he got onto the train and he sat next to a priest. The priest was totally abhorred by this man. He thought maybe he should get up and go and sit somewhere else. While he was contemplating what to do, this man from the street saw that somebody had left a newspaper on the bench. So he picked up the newspaper and started looking at the newspaper. The priest is still debating whether to move or not to move. And then this man turns to the priest and says to him, "Father, maybe I can ask you, what causes arthritis?" "Arthritis?" says the priest. "I'll tell you what causes arthritis. Drugs, alcohol, women of the street, sociopathic behavior. That's what causes arthritis." "Oh," says the man, and he continues looking at his newspaper. The priest feels very bad. He's usually a very tolerant person. All of a sudden there's a stranger sitting next to him and he's shown all his scorn and all his anger. So he turns to him and he says to him, "I'm sorry, sir, I hope I didn't offend you, but I'm curious. Why did you ask me about arthritis?" "Oh," says the man, "I'm also curious because it says here in the newspaper that the Pope has arthritis." I tell that story only to say that it's usually I'm much more comfortable talking about arthritis, which I've been doing for the last 35 years, than to talk about what I'm going to talk about. In 1998, I had the opportunity through a joint fellowship program between the various universities here and Stanford University to go to Stanford for 6 months and do something else. And the something else was on the condition that whatever I would do, I would be able to bring back, and so that our medical center would be able to benefit. Now, I grew up in this country. I went to medical school in this country. Went to Hadassah, finished in 1969, and the medicine that I learned was paternalistic, what I would call authoritative medicine. So what moved me to finally decide that I would like to learn more about ethics was probably the following quote, and probably the most important slide that I'm going to show you. Doctors are men, they're also today women, who prescribe medicines of which they know little, for diseases about which they understand even less, for people about whom they know nothing. And it is that random, that contact between the physician and somebody he knows nothing about, in which we have a duty, we'll talk about duties in a second, to make something about this a new relationship between the doctor and the patient. Now, this is taken from Professor Steinberg. He's sitting here. On medicine, 21st century, patient-physician society. A lot has changed in the last few years. Advances in technology. We've heard about some of these today. What I can do and what is not necessarily what I should do. Healthcare economics. There was once a time whenever you wanted you could do. But if you want to give something to everyone, you can't give everything. And if you want to give everything, you can't give it to everyone. And who knows what's going through with the Obama and his plan. It's all related to money. Public awareness of healthcare issues. Professor Reches, who was here, has a sign in his office that I always quote. It says there, "Would all the Jewish patients please bring the second opinion first?" Because that is what is happening today. That is what is happening. The internet, they all come and they really have an opinion. They don't come with zero information. They come with some information, whether it be distorted or correct or not. Patients' advocate groups and the media, usually sensationalist, not really giving the whole picture. And of course there are also elements of negative elements in our society. Certain doctors, I now sit as deputy ombudsman in the Ministry of Health, so I see all the complaints from the whole country, so I see them based on greed, arrogance, deception, coercion. But probably the most important of all of them is this change over the last 20, 30 years of transferring the decision-making process to the patient and to make him a partner. And so the moral context of the doctor-patient relationship would be honesty, integrity, mutual respect, trust, empathy. Empathy is a very special thing. It's not to be a sympathetic, nice guy. There are a lot of nice guys. Empathy is what you can give of yourself. And there are a lot of doctors who have, if you put it in the bank, you can give. If you haven't put it in the bank, you have nothing to give of yourself, which is empathy. And of course, mutual goals between you and the patient. Professionalism. This is taken from Pellegrini. Few would argue that these are the basic elements of professionalism as regards medicine. Some would add some would take, but they regard to altruism, accountability, excellence. This is to exceed ordinary expectations. In medicine, in order to stand still, you have to run very, very fast. There's duties to accept commitment, to service, honor and integrity in the various things I've mentioned here, be fair, truthful, keep promises, respect for persons, humanism, collegiality and dignity. And there's another one which I have not over here, which I'll discuss separately in a few minutes. But the question that I asked myself when I went to Stanford, and that's why I went to do bioethics there, is can the concepts of ethics, values, and professional be taught? Can you teach it? Or is it something that students bring to them from their home? Is this what makes up their basic makeup from their family, from their culture, from their religion? This is who they are, and you cannot make somebody who's unethical, ethical, or you cannot make somebody who's amoral, moral, or is that even our purpose, to make somebody an unethical, ethical? This is the famous Georgetown mantra of beneficence, do no harm, and the physician in the middle. Even Hippocrates spoke about those two. Over the last 30 years, we've been introduced to autonomy, maybe a bit fanatically introduced to autonomy, but certainly in relationship to justice or distributive justice, allocation of resources, where autonomy often collides with justice. There are many things that are not in here, for example, sanctity of life, but as a teaching instrument for our students to try and define and discuss cases, this is very useful. So why teach ethics? Well, first of all, it's much debated. If you can't evaluate it, then don't teach it. How do you know if I'm teaching ethics today that it'll make an impact on this physician, on what he does 5, 10, 15, 20 years ago? I tend to show you that maybe you can evaluate it. Justification for treating. The practice of medicine is a moral issue. Clinical medicine is more than just technical skills. There's a value issue behind it. Ethics has its own content and method, and Professor Steinberg has written extensively. Ethics is as teachable as any other discipline. And you can make, the most important is not to make them ethical, but to make them ethically defensible decisions. If you make a decision, be able to defend it under ethical principles. So the goals of teaching, what I took upon myself, philosophy of medicine and principles, sensitize students to value issues, and we'll talk about these in a second, teach moral reasoning, highlight the uniqueness of the patient-doctor relationship. It's a privilege to be a doctor, not just a right. Who do you allow to touch you? All of a sudden you have an MD there and you can put your hands on a stranger, as I said on my second slide, just because you've got some license to do so. That is a privilege, it's not a right. And they place medicine in a broader social, professional perspective. It is not to teach the students to be ethical. What do you teach them? Well, what concept should be highlighted? If I was developing a course that's designed to foster empathy, respect, responsibility, commitment, what would be in there? I took this from, I spent last year 3 months in Florence, and met Donatella Lippi, a very nice a woman who's done a lot in medical education, and I like what she said there of turning high-tech medical performance into high-touch. This place in high-tech and high-touch I like, and so I'm quoting her. These are some of the topics that you would want if you were designing a course. It's got philosophy of medicine, principles, informed consent, professional things like truth-telling, confidentiality, and all other ethical issues. I will not go through this whole slide. There are many more, or you can add more. When to teach it? Well, in the preclinical years, you teach the intellectual tools and interpersonal skills, and this should be done throughout the whole curriculum in medicine, not only fourth year or third year. This should be a continuum. And what do you teach? Clinically, during the clinical years, you teach probably the resolving practical problems and integrating it in the medical curriculum. Who should do the teaching? Well, there's a big debate about that, physicians or non-physicians. In the world, there are anthropologists and lawyers and social scientists. In my opinion, clinical ethics should be taught by physicians with adequate ethics training. The benefits of clinical teaching and ethics, credibility with students, serve as role models, and they bring relevance and experience cases. How to teach it? Well, now becomes a problem. How do you teach it? Well, the easiest is frontal lectures. You arrange a course. Anybody can arrange a course. Those lectures, I told you the topics, but they have the least impact on a student over time. Seminars, small groups are better. Programs, simulated patients. There's a whole institute in Tel Aviv in which they've developed simulation and all different levels, which is very useful but very expensive. Role-playing, video interviews, there are movies, and what I like the best are case studies because they are there and they are available. So when I got back from Stanford, Professor Reches, who was already the head of a course on ethics, I changed the course. He passed the course on to me. And we give a course in ethics to the fourth-year students. It's prior to their first clinical clerkship in medicine, 30 to 35 hours. I've prepared a handbook in which there are papers. For example, the paper by Leon Alexander in 1949. He was the scientist in the trying of the Nazi doctors, New England Journal of Medicine, Medicine Under Dictatorship. There's the original 1927 paper by Peabody in the New England Journal of Medicine, and the secret of treating the patient is in treating the patient, and various, a handbook of different potpourri of things for students. The patients all get, we have in Israel a patient's rights law. There's a little booklet. All the students get the rights law book. It's for the entire class, only senior faculty. We try and make it compulsory, but it's very difficult to get all the students there, and it focuses on these various topics. These are the same topics I meant beforehand. But anybody can prepare a series of lectures. I spent a few years ago with a sabbatical, Solly Benatar in Cape Town, and who wrote the following, which is really what I wanted to do when I went to Stanford. You must present a framework of a conceptual framework that students and young physicians can grasp and build on, and to create a teaching milieu which fosters self-criticism and personal development. This must be a beginning of creating a career in which you are able to analyze patient by ethical standards and moral reasoning. So what I did already in the year 2000 was to start a program of teaching ethics at the bedside. And what I did in small groups, I didn't ask for permission, I just did it. If you ask permission, you never get permission. So I just did it, okay? Small groups of 6 to 7 students, get a small seminar by me on ethical principles and give them case studies. Ethical issues that impact on medical students. There's a specific issue of this transition from a lay person to a medicine person, the power of the white coat, how to introduce yourselves, and there's a myriad of specific problems that relate to medical students, and then they get a project. The project is to document a personal encounter with a patient, clerked by the student. They are to submit it to me, describe the pertinent medical facts, the principal ethical issue defined by the student, discuss and balance conflicting ethical principles, suggest how the dilemma may be resolved, and that's prepared 8 weeks into the 12-week rotation. They all submit this paper to me in writing. They have to include up to 5 relevant exercises. Each student gets individual feedback on his patient by myself, and he gets a chance to present his case and discuss it to his peers, which are the rest of the students. Up until year 2006, I had 228 students who had done this exercise. It was not compulsory. On the basis of what I'm going to show you, it's now become compulsory. Every student in the fourth year is required to give a paper. He does not pass medicine if he doesn't give a paper, and it's 10% of his grade in medicine. This has now become compulsory, and you will see in a second why. But at that stage, when I did the first compilation, there were 228, there were 204 had submitted cases. I now have close to 500 cases, and there were few who did not submit a case, claimed that they couldn't find a patient, and some did not know how to resolve the conflict. What kind of problems do the students bring me? Well, 90 or 37% brought a classical ethical dilemma: autonomy or form consent, withdrawing, withholding life support, restraining patients, ageism, resource allocation, decision-making, all things that we would recognize to be ethical issues. There were others who brought, 31%, who brought a professional issue: telling the truth, confidentiality, keeping promises, disrespect, surrogate family and patient relationships, disclosing mistakes, and, of course, intimacy, and we'll discuss that in a second. And they're the students who bring problems that relate only to the students, in terms of introduction, student doctor, learning student, soon-to-be doctor, very big problems in how you actually introduce a student to a patient other than just call him a student. But the students are afraid if you just call him a student, and the patient won't let the student examine him. So they've developed all kinds of euphemisms of how to get about this. And all you need is integrity, and just say, this is a student, he's a medical student, he will be a doctor in 3 years' time. Okay, and I only got where I am today because people like you allowed me to examine them 40 years ago. But you don't say that, and that's the problem. So what do the students bring me? What are the problems? What is the value in this exercise? I hope I'll convince you. Let's go through the first one. Student has this assignment. He goes down to the emergency room, and there's a 92-year-old man. He has metastatic cancer of the lung, and he has signed a living will in the presence of his sons that when and if a situation occurs that he cannot make decisions for himself, he will not be artificially ventilated or treated by heroic means. That's the wording of that particular document. He does want to have his pain well controlled, stipulated. Several months later, his sons bring him to the emergency room in severe pain and respiratory distress. The team, they're aware of his request and try to control his pain and breathing with small doses of morphine. His situation gets worse, not better, and he implores the doctors to do something. The student took this case and discussed the do separately and the something separately. And he used this case to discuss the issue of palliative care as a duty, and it's in the law, of providing palliative care. He also used this case to discuss a value system between some physicians who would say do something, although he doesn't want it, to relieve his respiratory distress, is to intubate him, although that's not what he wanted. And so what would eventually happen in this case is the doctor decided just to increase the doses of morphine, give him a palliation for his pain, notwithstanding the fact that it may hasten his death. The next case is just as important. A 78-9-year-old woman had Alzheimer's disease, came in because of the evaluation of anemia. She had 6.2 grams of hemoglobin. So she went to the gastroenterology department. She comes back with a report that she has a large tumor the size of an egg, 1 centimeter from her anus. Now that's palpable. And somebody along the line did not do a rectal examination and missed the tumor. So the teacher, could be me, wants to teach the 7 students to examine the patient, saying to them, if you know how to palpate a tumor like this, you will definitely save lives. But the patient is unable to give consent, and there's nobody around to do it for her. So the student writes, learning to palpate a tumor in order to help some yet undefined individuals in the future does not override autonomy and consent of the patient. So he and the other 7 students did not examine the patient. That for me is worth the whole course in ethics alone. Okay? But what the student did was discuss the issues and the duties of teaching and the duties of learning of a medical student. It's not just something you go to medical, you have duties. Because you're a medical student, it means that you have the duties, and as a teacher, you also have teaching, but in his opinion, it does not override autonomy. And then there are a few little cases like this. A 72-year-old man signed a consent form in the coronary care, in the catheterization, and he says to the student, I cannot read what I'm signing without my glasses. The student in this case was present when the doctor explained to the patient verbally all the complications of what he was going to do. And he basically concludes that the signing is just a procedure. It's more important that the patient gets the information. And this signing is just lip service, and the actual explanation is better. The next one was a 44-year-old woman who's been told that she needs open heart surgery because she's had pulmonary edema 4 times and she needs a mitral valve replaced. And what she says to the doctor is, oh, I'll do whatever my rabbi says. Now that irks up a lot of people because they would like her to exercise her own autonomy, and the fact that she's giving her autonomy to somebody else, especially if it's a man of the clergy, that doesn't make them too happy. But people do it all the time. They give it to their children, they give it to their spouses. Why not give it to their rabbi? But the student made an interesting point here. The student said to the patient, okay, whatever the rabbi says is fine, okay, if that's what you want. But you must know that you can change your mind. Okay? You can change your mind. And I think that is the important issue in that kind of case. The third one is a more interesting case. We had a man on our department, this man I knew personally, who was in heart failure on his 3rd heart. Now, he had a heart failure. He went to Los Angeles to my friend Hillel Lex in Los Angeles, who gave him a heart transplant. 5 years later, he needed another one, so he got another one in Los Angeles. Now he's 4 years later, his heart failure on his 2nd transplanted heart or his 3rd heart. And he demands or wants another where there's a long list of people waiting. The student chose this case to discuss the difference in resource allocation between scarce versus expensive, which I thought was very elegant on his behalf. What he basically said, that when you're dealing with a scarce resource like a heart, the rules must be made beforehand. So when this patient got his 1st heart, he should be told he's only getting 1 heart or only 2 hearts, and those are the rules, because somebody else is losing out. When we get to the stage when there'll be an artificial heart, this may be easier to answer. The next one is an interesting one where a young lady wrote to me. Her case was, we had a man on the ward, 78-year-old man, widower, living alone. His 5 sons are all dispersed all over Israel, and he has a caregiver with him. So he came in with a respiratory infection, and a very good relationship was hit up between this old man and the young student. 5 days, she sat next to him. When he left the hospital, he invited her to visit him at home. Okay. And she writes whether this is an appropriate thing to do. She uses the case to discuss the whole issue between intimacy between a patient and a physician. But in this particular case, where she felt there were no ulterior motives other than just because the fact that the man was lonely, and he certainly wasn't at home alone, to make the following point. She is under no obligation to visit this man. But if she promises that she'll visit, then she must keep her promise. In medicine, we give promises all the time. The thing is to keep them. You don't have to promise, okay? But if you promise, you keep it. Hippocrates, the last part of my talk, discussed the issue of confidentiality. Already in the Hippocrates law, he discusses the keeping silence and secret, and really confidentiality is a major part of medical professionalism. Patients would not divulge information if they knew this would be imparted to others. But can you teach that? Can you teach people confidentiality? Can you teach people the responsibility implicit in obtaining sensitive and private information from strangers? Let me show you few cases. So of all the cases that I received, there were 29 students gave a case in which they defined a problem of confidentiality. The first one is an easy one. A 30-year-old woman is hospitalized with frequent recurrent asthma attacks. She tells only the student that her husband beats her. So she fakes the asthma attacks to escape from him, so she gets 3 or 4 days in the hospital away from him until she fakes her next attack. Only the student. Well, the student is very clear on this. This is the law. This is not affect what she wants to do or not to do. This has to be reported. This cannot be remained with the student, and so forth. She tells the young lady that she will tell the social worker and the doctors, because this has to be dealt with. This is the law. You cannot keep information like this to yourself. What about the next one? There's another young lady who clerks the following patients. This is a 38-year-old man with acute hepatitis B. And he tells only the student, this young lady, that he suspects the source is an extramarital sexual contact. But he doesn't want that information in his record. So this is a young lady student. This is the information that she has. What does she do with it? Well, this particular lady, young student, did the following. What I like to teach is moral reasoning. You can all decide whether you think she did the wrong or the right thing. She went back to the patient after thinking about it and said to him as follows. I'm willing to respect what you want, but there are conditions. First of all, we will tell your wife that you have hepatitis B. That's our obligation, because if she hasn't got it, she can be vaccinated. Okay, that's how you got the hepatitis B is your problem. But there's another aspect. This is public health. You claim that you got this disease from a woman. We have to contact her. But maybe you gave the disease to other women, so we have to contact them. I have here the list, the name of the person in the Ministry of Health who deals with these issues. You have 48 hours, okay, from discharge, okay, to contact this man. If you don't contact him in 48 hours, the information is everybody's. Now, I don't know if that's going a bit too far for a medical student, but that's what happened, and his confidentiality was maintained. We have this case, which I think I've traveled the whole world with. A 44-year-old man with Wilson's disease, which is a liver disease, came into the hospital to evaluate whether he was suitable for a liver transplant. The record states, according to the student, there was a history of alcoholism. Patient strongly denies it. The patient and the student hit up with a very nice relationship, and the 4th hospital day, he sees the patient very angry and agitated. Student, what happened? Why are you so upset? Well, somebody stole my cell phone. And you know what I did? I went down to the 2nd floor, orthopedics, and I took somebody's cell phone. That's what he tells the student. So the student asks in his paper to me, is this information confidential? So I looked at before I read what he wrote as he discussed the case, I thought, what is he giving me? Of course it's not confidential. The man created a felony. He's got to report to the security. He stole. Student didn't realize it that way. The student says, on the one hand, he committed a felony, and it's my civil duty to report him. But he says, this is a hospital. This is not a simple situation. On the other hand, by such an action, I may indirectly kill him. The committee responsible for allocating resources, organs, may deny him a liver on the basis of him being unreliable, inferior social worth, a thief, just because the man, in a minute of indiscretion, went down 5 floors and took somebody's cell phone. Not so simple. I liked it, because that's what I try to teach, to think beyond and out of the box. Students, I'm not going to give you the cases. Very interested in the various shades of telling the truth. From lying to deception to non-disclosure to truth dumping. Doctors love to dump the truth. You have to tell them, so you give the patient all the information you can muster. There's no way he can use it in order to make a decision, but you've given him the information. Plenty of information. With jargon, without jargon, very easy. Misrepresentation, intentional or even unintentional quotation of one's own experience or the medical literature in order to sway the patient to come to a particular diagnosis, and of course there's coercion. This is a quote I love from Kennedy. The great enemy of the truth is very often not the lie, which is deliberate and contrived and dishonest, but the myth, persistent, persuasive, and unrealistic, and we're very good at that in medicine. So, what about those students who didn't present a case? Well, as I say, that's old hat because now it's become compulsory. Either they didn't understand the assignment, did not attend the course, apathy and immaturity. They once asked a journalist, what do you think about apathy and ignorance in our society? And he said, I don't know and I don't care. So, some of them just lack intellectual and reflective skills. This is not why they came to medical school. Some feel very threatened by this whole exercise. This is not very easy for them, especially when they have to present it to their peers. Unwilling to expose value judgments. These are value judgments, not whether they can learn the differential diagnosis of anemia. And I asked then whether this was a flag that we could look in the future for performance. So summary, case finding is very useful and challenging. They learn the observational and insight and reflective skills. They learn the language of ethical argument. They can apply ethical context at the bedside, not just something theoretical. They can identify and analyze problematic issues, and it fosters empathy, maturity, and involvement. Who should be doing it? These are the 5 Cs of Pellegrini. Should be clinically based, real cases, continuous, coordinated, and in my opinion, clinical ethics should be done by clinicians. And to create maybe the greatest clinician of all time is William Osler. Every case has its lesson, which is often but not always learnt. Thank you.
They have the 3 principles, autonomy, confidentiality, but also social justice as one of the fundamental principles. And I wondered if you thought how to integrate that in your teaching.
Well, I put it in justice as allocation. It has to be equal access, resource allocation. It's in the context of autonomy. And so you even see some of the cases that the students that I spoke to you about had entered this issue of access, allocation, social justice. Yeah. It must be in there. That's correct.
I just started with my medical students in Tel Aviv saying they had to devise a project on social justice and healthcare.
Okay.
So
that's nice. I like that.
Yes. I'd like to ask about issues of do we have any system of screening medical students for ethical, performance? And have you seen this in Hadassah? And do we have a system to actually screen these kinds of students? And any comment on that issue?
Over the last few years, the whole system of accepting medical students in this school and all the schools in Israel has changed. For the last 2 years, and this will be the 3rd year coming up now, there are 8 stations in which all the potential students go through. They're OSCE stations, of which 4 or 5 or maybe even 6 are ethically based. So the answer is yes, it didn't used to be. Based on all this, and I definitely think that it should be. There should be some way in which a student who wants to go to medical school should have thought at least about these issues. There's no way they can provide solutions, but be able to think out the problems. Ken, I agree with you.
Do you relate to cross-cultural issues in a multicultural situation as you have here in Israel or other places?
Absolutely. I could bring you cases, yes, absolutely. I mean, a large percent of the class is Muslim, Christian, and they bring cases. Everybody brings cases for all kinds. Yes.
I wanted to ask, talking about your answer to the last question, is there or have you found a difference on the average between the different the different ethnic groups and their degree of ethnic behavior? And what about those who study medicine overseas in order to get a license? Do they have to take a special course in ethics after they return before getting a license?
There's two questions. The second one's easier. I don't think they have to do that. What's happened here is that I have over nearly 500 cases. Never really analyzed them per se. It is my experience that those young ladies, okay, with a yeshiva background, okay, or some kind of ulpana religious training, someone's discussed these cases with this kind of thinking beforehand. There are certain segments that their cases relate to the authoritative aspect of medicine. They bring cases of refusal of treatment and have a whole lecture on its own on the various shades of refusing or not accepting what the doctor adheres to them as a breach of this I don't know what you can call it, power of that's invested in the doctor. But things are changing. We are now trying through the Ministry of Health, and hopefully we're going to get off the ground, that in the future, with the next few years, all subspecialties, when they go to their specialty examination, will have to have had a course in ethics. Now for example, good clinical practice for research, there's a course on the internet run by the NIH. You can take the course on the internet. In the end, you'll get a certificate. This could be done with the internet. It can be done. I think the time will come where all graduates, doctors, not students, should be, in my opinion, not a question, but even physicians would have to show some expertise in understanding ethical issues.
Okay, so I'd like to thank Professor Rubinow again. And thank all the speakers and